Hello, good morning. Today we are going to learn tissue permeability of drugs. Myself Prashant Nayak, Assistant Professor, Department of Pharmaceutics, NGSM Institute of Pharmaceutical Science, Mangalore. So what are the learning objectives of today's topic? Drug distribution. Steps in drug distribution we will learn. Factors affecting distribution like tissue permeability of drug, tissue size, perfusion rate. These all things we are going to learn in today's module. What is drug distribution? Distribution is defined as a reversible transfer of drug into one compartment to another. Since the process is carried out by the circulation of blood, one of the compartments is always the blood or the plasma and the other represents extravascular fluids and other body tissues. Distribution is a passive process for which the driving force is concentration gradient between the blood and extravascular tissues. Steps in distribution of drugs. Distribution of drug present in systemic circulation to extravascular tissue involves the following step. Permeation of or unbound drugs present in the blood through the capillary wall occurs rapidly and entry into the intestinal extracellular fluid. Permeation of drug present in the extracellular fluid unit through membrane of our cells and into intracellular fluid. This rate is rate limiting and depends on major factors. Factors like rate of perfusion to the extravascular tissues, membrane permeability of drugs. Now with this we will see the figure 1, which is the systematic steps involved in drug distribution taken from the reference 1 and 2. As you can see clearly, a drug comes, binds to the protein, and then it is released as a free drug in the blood. It crosses the capillary walls and goes into the extracellular fluid, from where it has to be transferred into the cell membrane. It goes easily across the cell membrane into the intracellular fluid, and then tissue protein binding takes place for the drug. So this is exactly the steps involved in distribution of drugs. What are the factors affecting distribution of drugs? Distribution of drug is not uniform throughout the body because different tissue receives the drug from plasma at different rates and to different extent. Differences in distribution among the tissues essentially arise as a result of number of factors which are given below. Tissue permeability of drugs. Physicochemical factors of drugs like molecular size, it depends, pKa, oil and water coefficient, physiological barriers to diffuse of drugs. Then it depends on organ or tissue size and perfusion rate. Now binding of drugs to tissue components. Binding of drug to the blood components, binding of drug to extravascular tissue proteins, miscellaneous factors like age, pregnancy, obesity, diet, disease state, drug interaction, all these effects. They are the miscellaneous factors of drug distribution. So coming to the tissue permeability of drugs. Of the several factors listed above, the major rate determining step in drug distribution is the rate of tissue permeation and rate of blood perfusion. If the blood flow to the entire tissue, body tissues are very rapid, uniform, differences in the degree of distribution between tissue will be indicative of difference in the tissue permeability of the drug, and the process will be tissue permeation rate limited. Tissue permeability of a drug depends on physicochemical properties of drug as well as physiological barriers that restricts diffusion of drug into tissues. Physicochemical barriers or properties of the drug. Important physicochemical properties of drug that is influences its distribution are molecular size, degree of ionization, partition coefficient and stereochemical nature. Almost all drugs having molecular weight less than 500 to 600 daltons easily cross the capillary membrane to diffuse into the extracellular intestinal fluids. The degree of ionization of a drug is an important determination in its tissue permeability. pH of the blood, extravascular fluid also plays an important role in ionization and diffusion of drug into cells. Most drugs are either weak acids or weak bases, and their degree of ionization at plasma level or ECF, pH depends on their pK. We'll see how permeation of drugs of unionized and ionized drug occurs as shown in the figure 2, reference is 1 and 2. Unionized gas crosses easily, depends on the low pK and the large K value, oil and water coefficient. Unionized drugs crosses the capillary pores, but it does not cross the cell membrane. So this is the problem with unionized drug. They have a large Ka value and a low water and oil and water coefficient. Now, what are the physiological barriers of drug distribution? A simple membrane or a membrane is a special structural feature that will be a permeability restriction to drugs to some tissues. Some of the important simple and specialized physiological barriers are simple capillary endothelial barrier, simple cell membrane barrier, blood brain barrier, blood CSF barrier, blood placenta and blood testis barrier. In this we'll see the first one, simple capillary. It is same as shown in the previous figure, in which the drug passes from the blood, crosses the membrane and easily goes inside. 500 to 600 Daltons, less than that molecular size, crosses very rapidly. The second one we will see, simple cell membrane barrier. In this, as you can see in the figure 3, plasma membrane and drug diffusion across it. Reference is 1 and 2. Protein drug binds together and forms a larger molecule, protein drug, whereas the free drug crosses easily and goes into the extracellular fluid. Then depends on the size, 500, 50 to 500, below 500 and 500 and less than 500. Some drugs crosses easily, which are molecule size of less, goes into the bulk of intracellular fluid. Some drugs 50 to 600 Daltons, they also crosses. Some requires a carrier. So it is a carrier mediated. The carrier takes it from the cell membrane inside the extracellular fluid as shown in the figure and then gives it inside the intracellular fluid. Some drug cannot cross the cell membrane. So this is the first type of barrier, we call it as simple cell membrane barrier. The next barrier is called as blood-brain barrier, where majority of drugs do not pass. Only those which are used as diazepam, they cross the blood-brain barrier. This is because of the capillary endothelial tight walls, tight extracellular junction, astrocytes, pericytes, and basement membrane which forms the layer after layer. And you can see it is a sandwich layer where the drug which is highly lipid soluble only passes. Other drugs can't pass through it. So this is the barrier which we call it as third barrier, blood-brain barrier. The figure reference is taken by 1 and 2 references. Blood CSF barrier, cerebrospinal fluid. In this also we can see there is an open junction where drug can go. Highly lipid soluble can pass, but there is a capillary endothelium, extracellular fluid, tight intracellular junctions, epidermal cells which helps the drug not to cross and they form barrier. So only the drugs which are highly lipid soluble can pass through this membrane. We call it as a blood CSF barrier. Blood placenta barrier. In this case, the placenta doesn't allow of the drugs to pass and go to the fetus. So they have a first maternal vein, artery which is connected, which are junctions. They are tight junction, then a placental barrier which is a thick barrier, and then there is a fetal artery and fetal vein which is connected to it. So it's difficult to pass through the blood-brain barrier, placenta barrier. Next one, we have organ tissue and perfusion rate. Distribution will be perfused rate limited when drug is highly lipophilic. Membrane across which drug is supposed to diffuse is highly permeable, such as those of the capillaries and muscles. Whereas only the highly lipophilic drugs such as thiopental can cross the most sensitive barrier like blood-brain barrier. Highly permeable capillary walls permit passage of almost all drugs except those bound to plasma protein. In both cases, rate limiting step is the rate of blood flow or perfusion to the tissue. Greater the blood flow, faster is distribution. We will see one table which shows about relative volume of different organs, blood flow, perfusion rate, and the total body volume. Lungs, which is highest, highly perfused. Lungs, kidney, liver, brain, you can see in the figure. The percentage volume is 0.7, blood flow 500, cardiac output 100, perfusion rate 10.2 is the highest. As compared to the moderately perfused muscles as well as skin, it is 42 1020 cardiac output, whereas the perfusion rate is very low, 0.034. Poorly perfused organ like fat, adipose tissues, and bones, they have also very less, as you have seen in the table. So this is a relative volume of different organs of highly perfused, moderately perfused, and poorly perfused, how they behave and what is the perfusion rate. So more of the blood flow in the region, there will be more perfusion and more drug distribution. The Kt by B is the tissue blood partition coefficient of the drug when the first order distribution rate constant K is given as Kt perfusion rate divided by Kt by B. Distribution half-life is given by 0.693 K or K1, and then it is equal to 0.693 K T by B divided by perfusion rate. The extent to which a drug distribution is distributed in a particular tissue or organ depends on the size of the tissue volume, and tissue blood partition coefficient of the drug. Binding of drug to other tissue components. The drug in the body can bind to several components such as plasma protein, blood cells, hemoglobin, blood component, and extravascular proteins and tissues. Now, what are the miscellaneous factors affecting drug distribution? Age. What happens in age? Different distribution pattern of drug takes place. Total body water is much greater in infants than in the elderly. Fat content is higher in infants than elderly, so drug distribution in infants. Skeletal muscles are less in infants than in elderly. Organ composition, the blood-brain barrier is poorly developed in infant. Myelin content is low, cerebrospinal fluid flow is high. Hence, greater penetration of drug in the brain will take place. Plasma protein cannot be low, or low albumin content in both infants and elderly. Problem for drug distribution. Pregnancy, growth of uterus, placenta, fetus increases the volume available for distribution of drug. Fetus represents a separate compartment in which a drug can distribute. Plasma and the ECF volume also increases, but there is a fall in the albumin content. Obesity, high adipose tissues were poorly perfused can take up large fraction of lipophilic drug despite the fact that perfusion is low. High fatty acid in obese patient alter the binding characteristic of drug. Diet, high in fats increase free fatty acid level in circulation, thereby affecting binding of acidic drugs such as NSAIDs to albumin. Disease state, mechanism may be involved in alteration of distribution, altered albumin, other drug binding protein concentration, alteration or reduced perfusion to organs or tissues, and altered tissue pH. Drug interaction that can affect the distribution are mainly due to differences in plasma protein or tissue binding of the drugs which occurs. References is taken by Shagil and Brahmankar. Shagil book is Applied Biopharmaceutics by McGraw-Hill edition. Brahmankar is Biopharmaceutical Pharmacokinetics, Vallabh Prakashan. So today what we have learned, we'll summarize the things. What exactly is a blood-brain barrier, blood placenta barrier, blood CSF barrier, simple capillary wall barrier, and how the tissue or the blood-brain barrier things develop. That's all for now. Thank you. Have a nice day.